Assalamu alaikum ji. I hope everybody can hear me. The topic for today is retinopathy of prematurity. Well, a very diverse topic, and probably one of the topics where a neonatologist, a general ophthalmologist, a pediatric ophthalmologist, and a VR surgeon, they all converge onto this particular topic. And also, sadly, one of the most underdiagnosed and maltreated diseases in our setup in general. And retinopathy overall is quite a point of concern in countries like Pakistan because it is mainly concerned with malnourishment and maldevelopment. So, when I talk about retinopathy of prematurity, I've tried to keep it simple so that today we may take home some key points from this presentation and better our treatment. As a brief definition, retinopathy of prematurity is the arrest of normal retinal vasculature development in the preterm infant with compensatory mechanisms that produce aberrant vasculature of the retina. Now, if we only look at the bold letters over here, you will be able to tell what exactly retinopathy of prematurity is about. And I will further explain it as we move on. So, I think the most important domain of this particular topic is the screening part. And this is where we mostly ignore our patients. So, a big chunk of my presentation will be focused on who, when, and how to screen. In the second part of this presentation, we will move on to the diagnosis and staging of this disease, which is very much concerned about the treatment plan. In this particular presentation, I will stop myself up to the point of diagnosis and staging because it would have gotten very elaborate. In the next presentation, we will move on to the treatment plan of retinopathy of prematurity. So the first question is who to screen. All infants that come to us and have a birth weight of less than 1500 grams, all infants, we have to screen them for ROP. All infants that come to us with a gestational age of less than 30 weeks. These are the two terms that we should have in our mind when a young infant comes to us in our OPDs. And thirdly, this is a gray area. If the infant has a birth weight between 1500 to 2000 grams and a gestational age of 30 weeks, but has had an unstable clinical course during the pregnancy, or if the attending neonatologist considers that this patient should be screened for ROP, we should screen that patient. So these are the guidelines that I've picked from American Academy. Moreover, there are certain algorithms that have come into play and can predict quite accurately the chances of ROP being present in that patient. For example, WinROP is one of those algorithms. What WinROP does is it takes birth weight into account, it takes postnatal weight gain into account, it takes levels of IGF-1, that is insulin growth factor 1, and IGF binding proteins into account, and there are some other factors as well. Not going into the detail. So WinROP algorithms, and there are some more algorithms as well, which accurately predict the chances of ROP being present in that patient. So we have to screen them as well. Second question, how to screen? Now, my knowledge mostly comes from book because I myself have not been screening many patients. I'm sure people who are concerned with pediatric ophthalmology will have a better opinion on that. The first method is by binocular indirect ophthalmoscopy. the usual method that we use over here in this setup as well and other pediatric setups as well. We use topical anesthesia. We use eyelid speculum for a better view. Before proceeding to the posterior segment, we have to inspect iris for any new vessels, because in the last stages of ROP, anterior segment signs can also present. And we have then to scan the retinal periphery with scleral depression. What do we have to see in that screening? I will be discussing in detail when we come to the staging of the ROP. Moving on, now there are more advanced techniques to screen for ROP as well. For example, one of them is photographic telemedicine. You take a photograph, very useful in the peripheries, and it is being used in parts of India as well and other areas as well, where you only need an optometrist to take a photographic medicine. You already have a set of protocols defined, and if that person finds it necessary, for example, one of the criteria that has been defined by photographic screening for retinopathy of prematurity, photo-ROP cooperative group, it defined another term, clinically significant ROP. So other than clinically significant macular edema, we now have another term. I also myself found out recently when I was preparing this presentation, that is clinically significant ROP. So if the person finds that this ROP is clinically significant, he can refer the patient to the center. I won't be going into the zone 1, zone 2 and zone 3. If any ROP is present in zone 1, stage 2 with no plus disease or up to 1 quadrant plus disease in zone 1, and in zone 3 if there is stage 3 with no plus disease or up to 1 quadrant of plus disease. What are all these zones and what are all these stages? It is coming up in the presentation later on. Along with that, there are also trials of artificial intelligence being incorporated with photographic telemedicine to screen these patients. Now, when to screen? Another very important question. We know who to screen, we know how to screen. Now, when to screen? First examination should take place between 4 to 6 weeks of postnatal age, or at gestational age between 31 to 33 weeks, whichever is later. Okay? When to screen? This is a follow-up protocol, quite extensive, but to summarize it, for diseases that are more severe in the later stages or lie in zone 1, usually need a more intense follow-up program, and the diseases with lesser severity and towards the periphery of the retina require a less strict follow-up plan. Moving on to the diagnosis and staging, there are 5 points very important when we come to diagnosing and staging retinopathy of prematurity: the location, the extent, the severity, whether or not the plus disease is present, and whether or not the aggressive ROP or the rush disease is present or not. Okay, now this chart may look very complex right now, but I will be elaborating it step by step to make it further simplified. As I said, location, extent, severity, plus disease, aggressive ROP, we have to categorically classify ROP in order to devise the proper treatment plan for that particular patient. First of all, the location, very important. It looked very difficult on that chart, but to simplify it in this diagram, the zone 1, the most posterior part, this is the blue circle. Basically, the radius extends twice the distance between the optic disc and the fovea. Pura distance, this is zone 1. Then zone 2 is slightly towards the periphery. You can see the red circle. That is twice the distance between this is the distance between fovea and the nasal ora serrata, whereas zone 3, the crescent, anterior crescent left on the temporal side. So in general, if the disease is lying in zone 1, usually you have to treat it. And if it lies in zone 3, you may or you may not have to treated depending on the severity of the disease. Now, the second point was the extent. It's pretty simple. You have to define it in the clock hours, how many clock hours are involved, and if it is continuous or not continuous. So I will, after location, I will move straight away to the severity, because these three factors are the major defining factors in the treatment of ROP. That is the location of the patient, the extent of the patient, and then the severity of the patient. So when we talk about severity, there are 5 stages: stage 1, 2, 3, 4, 5. This is stage 1. In stage 1, as you can see these arrows over here, it's the demarcation line. You only see a demarcation line in stage 1. This is the stage 2. This is a ridge. That line has further solidified and turned itself into a ridge. This is stage 3. When a fibrovascular bundle has formed in that area of ridge and has extended itself into the vitreous. This is stage 3. Then stage 4 is divided into 2 parts, stage 4A and 4B. This is 4A, basically subtotal retinal detachment that is not involving the fovea, as you can see in this diagram. And this is the photograph of a subtotal retinal detachment of ROP not involving the macula. Stage B, obviously, then is the subtotal retinal detachment involving the macula. This is the photograph. You can see all that fibrovascular bundle extending all the way to the macula. Then stage 5 has 3 stages: 5A, 5B, 5C. That is total retinal detachment. So if the total retinal detachment is present, but you can still see the disc, as you can see over here, probably somewhere around here, you can see it. This is an open funnel retinal detachment. This is classified as 5A. If you move on further, 5B, when you cannot appreciate the disc or it's a closed funnel, then it is called a stage 5B. This is a stage 5B disease. And 5C we categorize when along with 5A or 5B we have anterior segment changes as well. That could be a flare, that could be Mayo's pupil, that could be vasculature of the iris or anything. So going all the way back to that table, well, I'm sure this looks a bit more easier now to understand. We have done the location as well. Zone 1, Zone 2, Zone 3, we've done the extent. We've done all these severities up to the stage 5. And then we have to see if the patient has plus disease or not. The criteria of plus disease is vascular dilation and tortuosity within zone 1, iris vasculature, and vitreous haze. If any of these factors is present, we say that a plus disease is present. And then there is aggressive ROP, also called rush disease. It's a severe form of ROP and characterized by the posterior location. As I told you, if it is posterior, it is something serious and to be managed on an urgent basis. And in case there is a prominent plus disease, again, you call it aggressive ROP. And sometimes iris rubeosis may be present. And the peripheral retinopathy may be ill-defined. All these factors we need to devise a treatment plan for the retinopathy of prematurity. And that, unfortunately, I have not covered in this presentation because I had a feeling it would be a lot of information overload. We will be covering it in my next presentation, inshallah. Thank you.
Okay, excellent presentation, well planned and thoroughly explained. I recall my time in Sydney, Australia, when I spent time in pediatric ophthalmology unit in Westmead Hospital. So there, the consultants would take a patient of ROP as an emergency. Whenever a call would come from intensive care unit, we will rush to the ICU, neonatal ICU, NICU, and then we will dilate the patient with cyclopentolate and midazolam, and we will examine the patient whether it is Friday evening or Saturday evening, whatever date or time it is. So, and if there is finding, we will again rush to department, take the RETCAM is a retinal camera, a big structure like this, and it as a junior, it was my responsibility to drag the RETCAM to the NICU, and there we would take the photograph there and then. So the treatment usually we performed the next day in the morning under general anesthesia. So for the examination of the patient, you require to have somebody who can handle neonatal apnea, because these young children, they hold their breath and they can become cyanosed, and for ophthalmologists it is difficult to treat or do the CPR sort of thing. हमारे तो हाथ पैर फूल जाते हैं छोटा बच्चा जब सांस रोक ले और नीला हो जाए तो somebody, a trained staff at least, should be present, and this screening should be done in neonatal intensive care unit or operation theatre, not in the ward, not in the OPD. So this is a must. We usually wrap the neonate in cloth so that he or she cannot move. But the patient cries during the examination, but irrespective of crying, we examine. So there, the logic was whenever you see ROP, you photograph it so that you document the progression, date and time, and the treatment given. So they will take a photograph before the treatment, a photograph during the treatment, a photograph after the treatment that we have applied so many laser burn. He will discuss the management next time. But RETCAM is very valuable in documenting. You cannot have photograph without RETCAM, and you cannot prove that you did the treatment whether it was required or not. So, coming to the screening protocols, every country has its own criteria. So, Americans have their own, Britishers have. Pakistan, there is organization ProPara, which deals with the retinopathy of prematurity. They hold sessions in national conferences, and they, as far as I know, they have outlined the criteria as 1500 gram and 32 weeks of uh, gestation. So the problem is if you decrease the threshold, there will be lot of patients you will have to screen. If you bring the threshold up, then there are chances that you will miss a few cases. So you have to make a compromise and in between so that the workload is not much and you do not sort of miss the cases. See, there should be a ROP coordinator, a non-medical person who sort of details the patient's relatives, tells that this is important because treatment is difficult. Prevention is the best solution. You identify the ROP at line or ridge stage and you treat it, and it's like having no disease. But once there is fractional retinal detachment, I have not seen any successful surgery. Maybe you can illuminate more. It's difficult to treat. So prevention is the main treatment. And so we have to make liaison with the pediatric unit. We have to tell that. child specialist of the institution that okay, so this is the criteria. Instruct your staff to send the patient whenever the patient crosses lines. Weight less than let's say 1500 gram, age 32 or 35 weeks. So it should be known to everyone in the neonatal intensive care unit that this, if the parameters are less than that, you will send a call to the eye specialist and eye specialist will come. See, dilating the pupil is difficult in neonates. It takes extra efforts, and scanning the retinal periphery also takes some time. You have a learning curve, especially with indentation. So you have to indent the temporal retina to see the avascular area. So, management next time we'll discuss. So these are a few practical points. You want to add something?
सर जो ICROT की थर्ड क्लासिफिकेशन है वो लेटेस्ट है, वो 2021 में आई है। उस पर उन्होंने पोस्टीरियर जोन को इंट्रोड्यूस किया। वो जोन 1 के मार्जिन से शुरू होता है, इट एक्सटेंड्स टू दिस डायमीटर। ये एक चीज ऐड करें, और उन्होंने एक टर्म इंट्रोड्यूस करा कि नॉचिंग की, कि अगर जोन 2 में आपने स्टेज 2 देखी है और सिर्फ 1-2 क्लॉक आवर्स वो एक्सटेंड करी है जोन 1 पे, तो आपने मेंशन करना है विद नॉचिंग जोन। तो ऐसी टर्मिनोलॉजीज हैं जो नई इंट्रोड्यूस हुई हैं, इसमें रिग्रेशन की, एक्टिवेशन की टर्म्स हैं, तो वो थोड़ा सा रिवाइज करना है। ICROT ठीक है, और
हाँ
बाकी से ट्रीटमेंट में थोड़ी सी है लेटेस्ट
हाँ
गाइडलाइन को, जब
ट्रीटमेंट आएंगे तो you see once you start a project in the west they make a plan. Okay, we want to start this service. How much resources are required? 1% ROP coordinator, 1% for screening ROP, one for maintaining. So they first provide the resources and then start the services. Because if you start services and you sort of neglect it, और आप जल्दी में आपने कोई मिस कर दिया, द पेशेंट विल सू कि जी ये इंडिया में इस तरह हुआ है, पेशेंट उन्होंने जो पीडियाट्रिक यूनिट है उसको सू कर दिया कि इन्होंने रेफर नहीं किया। सो अभी आरओपी का एक आप कह लें तूफान आ रहा है, और आहिस्ता आहिस्ता क्योंकि न्यू नेटल सर्वाइवल इंप्रूव कर रहा है। पहले न्यू नेट सारे मर जाते थे जो प्री टर्म हो, अब वो बच जाते हैं क्योंकि पीडियाट्रिक सर्विसेज बेहतर हो रही। सो हम वेस्ट में तो ये 10 साल पहले आया था और उन्होंने कंट्रोल, अब हमारे यहाँ अब आ रहा है कि जी चाइल्ड स्पेशलिस्ट थोड़े एक्टिव हो गए हैं, फैसिलिटीज बेहतर हो गई हैं, ये बच्चे जो प्री टर्म होते हैं सर्वाइव कर जाते हैं, पहले करते नहीं थे। सो अभी ये इंसिडेंस बढ़ेगा और आपको प्री टर्म बच्चे नजर आएंगे। तो अगर हम नई टाइमली ट्रीटमेंट करेंगे, ट्रैक्शनल रेटिनल इट प्रोग्रेसेस इन डेज, मतलब है 3-4 दिन में अगर बच्चा रेटिनल डिटैचमेंट हो गई तो फिर आप कुछ करने के काबिल नहीं। सो पेशेंट 4 वीक्स आफ्टर डिलीवरी आपके पास आए, आप हर 2-3 हफ्ते के बाद उसको दोबारा देखें, जो भी प्रोन पेशेंट्स हैं, तो आप प्रिवेंट कर सकते हैं। तो लॉट ऑफ मोटिवेशन इज रिक्वायर्ड ऑन द साइड ऑफ द पेरेंट्स कि वो हर 2-3 हफ्ते बाद लेके आए, 2 घंटे 3 घंटे इधर गुजारें बच्चे को। आप जी फर्स्ट करो देखते हैं, डायलेट करने में घंटा लग जाता है, फिर उसके बाद देखने में आधा घंटा फर्स्ट करो, तो काफी तो लेकिन अगर वो ये नहीं कैच करेंगे तो फिर पेरेंट्स जो हैं वो अब नाराज होना शुरू हो जाएंगे।
सर 2-3 हफ्ते से कितनी देर तक देखते रहते हैं?
हाँ जी,
तो ये क्राइटेरिया जब तक रेटिना पूरा वस्कुलराइज नहीं होता, टेम्पोरल पेरिफेरी तक वस्कुलराइज जब हो जाता है उसके बाद रिलेशन स्टार्ट। एक ये कि उसमें जो न्यू वेसल्स बनी है वो रिग्रेस होना शुरू हो जाए और पूरी तरह से रिग्रेस हो जाए, और जो पेरिफेरल वस्कुलर रेटिना है आपको लेज लगता है तब तक। और जिन पेशेंट्स को आपने वेसल दिया है, बेवैक्सीजुमाब दिया है, उनमें 7-8 मंथ्स के बाद भी आरोपी दोबारा रीएक्टिवेट हो सकती है, तो उनका लॉन्ग टर्म फॉलो ये कोई वो फिक्स क्राइटेरिया नहीं है कि इतने हफ्ते तक हमें देखना है। आपने पेशेंट टू पेशेंट पे ही है, जिस पेशेंट को आपको लग रहा है कि ये नहीं आएगा दोबारा दिखाने, तो बेसिस पे बताते हैं जो ऑक्सीजन को हम बड़ों में तो होता है ना 3.5 है या 4 है बच्चों में हाँ बच्चों में 1.5 है
2 मिलीमीटर
में इन्फेंट के इनिशियल गाना होता है ना तो उस पे 1.5 है उसके बाद हर 6 मंथ्स के बाद आपने 0.5 मिलीमीटर ऐड कर देना जैसे अगर 6 मंथ्स पे आए तो आप 2 मिलीमीटर देना 1 ईयर पे आए तो 2.5 डोज हाफ
हाँ डोज
सबसे मुश्किल होता है डायलेशन एरिया डायलेशन के लिए स्पेशल वो ड्रॉ तैयार करते हैं क्योंकि अगर आप अच्छा डायलेट नहीं किया आप डायरेक्टली मिस कर गए तो आप डायग्नोज नहीं कर सकते
कॉम्बिनेशन है 0.2% साइक्लोपेंटोडेट और 1% फिनाइल केमिस्ट्री में 2.5% फिनाइल है लिखा हुआ है इसलिए भी दे सकते हैं तो वो बड़ा ग्रुप होता है जो मर्जी दे दें नहीं अगर आरओपी है तो ग्रुप डायलेट होता है सबसे बड़ा साइन है आरओपी अगर आपने नहीं देखा और तो ग्रुप डायलेट नहीं हो रहा तो फॉरेन क्यों मिल जाता है कि हम देखेंगे तो कुछ ना कुछ होगा
डायलेशन और इंडेंट करते हैं की पॉइंट या करेंगे तो
हमारे तो सर इधर हॉस्पिटल डिलीवरी का कंसेप्ट ही नहीं
हाँ देखिए वो असल में ये होता है ना कि अगर आपकी सर्विसेज आ जाए ना इस लेवल पे तो फिर सारे शहर में वैसे मशहूरी होती है यार वहाँ पे होती है वो फिर लोग धड़ा धड़ा आते तो हम इसलिए मैंने तो अभी तक शुरू नहीं किया था इसलिए कि एक बंदा पेशेंट को समझाने के लिए है यार हर 2-3 हफ्ते बाद आना है ये ना हो एक वो मिस करें उस दौरान में आरोपी हो जाए और वो बाद में आ गए जी आपने तो हमें बताया ही नहीं था कि 2 हफ्ते बाद आना है
गायनोकोलॉजिस्ट के लेवल पे ही काउंसलिंग होनी चाहिए कि अगर ये देखिए
हाँ
डिलीवर हुआ तो आपने ये पॉइंट्स
वो चाइल्ड स्पेशलिस्ट आमतौर पे क्योंकि डिलीवरी के फौरन बाद वो इन्वॉल्व हो जाता है ना तो चाइल्ड स्पेशलिस्ट को ऑन बोर्ड लेना वो रेफर करते हैं कि
आप
जी
सिडनी में सर कब थे जब ये निको में आप
मैं 2012 में था
2012 में वहाँ पे एक एस्टेब्लिश्ड
हाँ बिल्कुल वो तो
अवेयरनेस
मुझे अभी भी याद है एक पेशेंट वो मिडल ईस्ट की फैमिली थी फातिमा मरीज का नाम था वो रात को हमने को 9-10 बजे देखा तो उसने कहा यार इसको अभी रेड कैम को धक्का दे के लाना वो मेरा काम था इसलिए मुझे याद है अच्छी तरह के वो काफी फासला था वो डिपार्टमेंट से जो न्यूनेटल यूनिट खैर अगले दिन सुबह अंडर जीए हमने वो वीकेंड था और फिर भी वो किया हमने तो मतलब है उसमें लेट नहीं करते कि ये 2 दिन हफ्ता इतवार वीकेंड है तो चलो यार परसों कर लेंगे मंडे को कर लेंगे नहीं उसी वक्त ठीक है जी थैंक यू वेरी मच बहुत शुक्रिया हाँ हाँ बिल्कुल
बता रहा था हमारे 3 महीने से